welcome to the Road to Genome podcast. I'm your host, Helen Bethel, Workforce Development and Education Lead. Today, I'm delighted to be joined by Gill Moss, a fellow colleague at the NEY Genomic Medicine Service. Hi, Gill.
Hi, Helen.
Thanks so much for joining us today. So can I start by asking you then, what's your current job title?
Unusually, I've got two job titles.
Okay.
One is Nurse Director for the North East and Yorkshire GMSA, but I've also just been successful at getting the title of Director of Nursing and Midwifery and Nursing and Midwifery Champion for the Generation Study Northwest GMSA.
Wow, they sound big titles and big roles. Congratulations on your new role. So can you tell us a little bit more then about what those titles mean?
Fundamentally, it's raising awareness of genomics over the north of England, with nurses and midwives being at the core of who we're trying to get on board.
Fantastic. And is this what you'd always aspired to do?
Absolutely not. Absolutely not. No, I mean, I started as regards whether or not I wanted to be a nurse. Then this started at the age of 6, actually. And it was, for anybody who remembers the magazine Twinkle, in Twinkle was Nurse Nancy with her teddies. And that's what sold nursing for me.
Okay.
And I was bought a nurse's outfit for Christmas. And the rest is history.
Fantastic.
I've literally followed my dream, actually.
What a wonderful thing to do, to say that you followed your dream. That's fantastic. So from 6, you wanted to do that. So literally from school, you knew...
I started applying in the lower 6th at school. Everybody else wasn't thinking about applying for university until the upper 6th. But I obtained a place in London, actually, to start my nurse training.
Okay.
At the London Hospital in Whitechapel. However, it was during the upper 6th year when I decided I actually didn't want to go to London. And there was a children's hospital television programme on at the time. And that attracted me to children's nursing. And of course, living in Manchester, we've got the Royal Manchester Children's Hospital as a training school on the doorstep.
Yeah.
So I applied there and I was very lucky enough to get a place. And I started in September 85.
Fantastic.
And been there ever since.
Really?
So 38 years.
Yeah. What a dedicated service, such a long time. Well
Yes.
done. That's an incredible achievement. Does it run in the family then? Are you from a family of nurses or...?
Funnily enough, no, it doesn't at all. However, there's myself with 2 sisters and I have 3 cousins. And out of the 6 of us, there's 4 nurses.
Really?
Yeah, there's Sarah and Janet, who are my cousins, who work at the Royal Bolton.
Yeah.
And then there's my sister who works in mental health in Wales. And then there's myself. So it's a bit unusual, really.
Yeah.
There's teachers in our family.
Yeah.
Going back through the generations, but certainly not anything medical.
Yeah. Fantastic. So you mentioned one of your sisters is mental health. What are the other 2?
Sarah works at Bolton and she's in endoscopy. So I have had conversations with her about Lynch syndrome.
Great.
And my other cousin works in A&E. Janet works in A&E at Bolton.
Fantastic. So almost de novo for your generation, but very much in the family now.
Yes.
So going forward, is there any other, kind of in your children, the next generation, are any of them in kind of medical fields?
No.
So it stops in your generation.
It has
so
stopped,
far.
yes.
Yeah.
But what will happen with grandchildren, who knows?
Yeah,
that's
exactly.
yet to see.
Yeah. So just going back to your journey then, so you mentioned about the fact that you wanted to stay local and to do your training at the Children's Hospital. So what was your journey like to get there then from applying from school? What happened next?
So I started in September. I got the job. Got the role because, of course, it was a paid role in those days rather than bursaries and in the way it's managed now. And it was a 4-year combined course. They don't do RGN, RSCN anymore. You have to choose at the beginning of your training which arm you want to go down. And I chose the 4-year combined. On qualifying, I worked on one of the wards at the old Children's Hospital based in Swinton on Ashby Ward, which had metabolic patients, renal patients, dermatology, rheumatology, neurology, a real mix of patients on there. And then after about 18 months, so I only did 18 months of shifts, and then I moved into a 5-day endocrine day case unit, which meant I got Monday to Friday.
Great.
Which was marvellous. And I never looked back from there. I stayed there for 9 years, even though I was there to cover maternity leave. I stayed there for 9 years, and then an opportunity came up to work with the metabolic team. And I was lucky enough to get that, and I stayed there for 22 years.
Wow.
A long time, and saw a lot of changes. We were heavily involved with metabolic clinical trials, taking patients from all over the world for that. And I didn't do the research myself, but my staff, I recruited staff to undertake the research and carry out the clinical trials, which was drug therapies, enzyme replacement therapies. And like I say, did that for 22 years. During that time in 2009, the old Children's Hospital closed and we moved to the new site of the Manchester Royal Infirmary site in central Manchester, which was working alongside the academic institutions of the university and bringing us all together on one site. And our department merged into the Genomics department.
Okay.
So we were all on the same floor. We were sharing the same offices, in effect. And the laboratories were there. And it was there, I suppose, even though I had worked for 22 years in the metabolic field, which is all inherited disorders, all genetically inherited disorders, that's, I suppose, my first exposure to genetics outside my own field of medicine. And the 100,000 Genome project kicked off in 2012. And it was probably in about 2013, 2014 that the chief nurse of our trust was invited to a meeting with Dame Sally Davis and the chief nurse at the time in London. And she, in effect, cascaded that invite down to the lead nurse of genomic medicine, as I was then. And I went along with the chief nurse of St Mary's, which is the directorate in which my department sat. And we went down to that meeting, and I was, in effect, told that if there was any work to do, then I would be doing it. And as a result of that, the ambassador for the 100,000 Genome Project job became available, for which I went for. And I thoroughly enjoyed it. That role finished, but then within about 6 months, an opportunity arose to work at the Genomics unit. So I went for that role as a rare disease lead nurse with the Genomics unit. I worked with them for 18 months. And of course, at the end of that, that's when the GMSAs were born. And of course, they wanted nursing staff. So I applied for the Northwest role and got that. Started in post, and then about 6 months later, an opportunity came to be part of the Northeastern Yorkshire. So hence, I'm now over both sides of the Pennines. And I left metabolics completely about 3 years ago. When I joined the Northeastern Yorkshire GMSA, I then left the metabolic team. And here I am today.
It's lovely to hear how your kind of transition into genomics was so gradual and feels very natural as you're just kind of describing it. And so your move, as you say, your physical move from your old department to the same corridor as genomics was the one that really kind of nudged you into that step of taking on that kind of more genomics focused role. But can you, on reflection, can you pinpoint when it was that you first heard of genomics in your training, was it? Or was it on the ward or a particular case? When did it first kind of come to...
Genomics or genetics?
Either.
Or genetics, in effect. I've worked in genetics ever since I started working with the Willink, because the full title was Willink Biochemical Genetics Unit.
Of course.
And so everything that I dealt with was based upon, parents carrying those specific genes and then babies being born with those disorders. Or, of course, with X-linked disorders. Then, of course, it's the mum that carries those genes. So it's been part of my, I'll say, daily living anyway. So it was a natural progression to go down this pathway. Had I planned it? Absolutely not. But has it been good? Absolutely it has.
Fantastic.
Yes, I'm very pleased I made the move.
So I think, we still struggle today with, undergraduate nursing courses and the amount of genomic content that's in them. There's no standard and it varies quite considerably. Do you remember actually any genomic content in your training, or was it just something that was kind of by osmosis that kind of came? Osmosis.
No, definitely not. I suppose the exposure to the carrier status and talking about genotype-phenotype correlations, all that has come through working at the Willink.
Great. So thinking back to your clinical work and maybe those early days, can you remember a case that maybe involved genetics or genomics, as it was generally referred to then? Can you remember a case? Is there any cases that stand out to you where genomics was a big factor?
I suppose it's when you have the unfortunate situation where you have families going through genetic testing to get diagnosis for the patient at the same time as being pregnant with a second child. And the risk factor of the second child being affected, but potentially too late for any kind of interventions. And that unfortunately can happen, and it has happened on a number of occasions. And it's the unfortunate luck of the draw.
Yeah.
But yeah, there's been a few families over the 22 years
that have stood out for those reasons.
For that.
Yeah.
And then you have some families where they have 4 children who are affected.
Yeah.
Despite genetic counselling and the 1 in 4 risk for each pregnancy, it can happen.
Yeah.
More than once, of course.
It can, yeah. So how has nursing changed then during your career from start to today?
Oh, crikey, I would say there's been a lot of changes. There's advanced technology that's used now, whether it's on the wards, whether it's in theatre, point of care testing. And of course, we're in a situation now where we've now got the point of care test that's hopefully going to be commissioned going forward for genetics. And of course, this is the study that was carried out in Manchester using a point of care test to find out whether or not a baby has an underlying potential to go deaf after having 1 dose of gentamicin. And now we have the gene drive device, which we can test a baby's saliva and within 20-25 minutes can determine whether or not that baby should receive. It is incredible, actually. It's quite mind-blowing and where the advancements are and where they can go. This is just the start of it. And it's incredible as to what we can do. But there's other areas. We've got the specialisation. There's a lot more collaboration of people working together rather than working in silos. Teams are much more prepared to work together, and obviously it's for the best interest of the patient to get that holistic care. So there's lots of different areas, and of course genomics is one of them.
Yeah, and I think what's so great over the last kind of couple of decades is seeing the role of the nurse within that really exploded onto the scene. So no longer is the role of the nurse just that care role for the patient, although that still very much is at the core. If you speak to most nurses, it's generally at the heart of it all. But actually roles such as your own that are, kind of exploding onto the scene, and it being a nursing background rather than a medic background is, I think, a real amazing step forward to bring all those wonderful skills that nurses have into roles such as your own. So I hear what you're saying in terms of the technology improvements, to go from a point, about 10 years ago where it would take 2 years to get a genomic result back to getting to the point where it takes 20 minutes is just a phenomenal increase. But again, alongside that technology drive is also those nursing roles that have been brought into that. I think it's a huge positive for the profession. So that testing sounds amazing. And can you just explain a little bit about what gentamicin is?
So gentamicin is an aminoglycoside, so it's a specific antibiotic, and NICE guidelines suggest that's given to babies when they go into a neonatal intensive care unit because of the prematurity and the immaturity of their immune system. Then they need antibiotics to protect them from any kind of infection.
Okay.
So what the study looked at was testing babies on entry into the department, so not slowing down the patient pathway, still within that golden hour of entry into the department. They would have a saliva sample taken, and the machine would tell you whether or not that baby carried a certain variant, which would indicate whether or not the baby should be given gentamicin, or in some cases, 1 in 500 cases, a baby shouldn't be given gentamicin, which would in turn protect them from losing their hearing, which they can do after 1 dose for life.
That's incredible. Was it able to pick up any babies who would have been susceptible?
coincidentally, within the first week of the trial that took place over in Manchester and Liverpool, a baby was picked up in the first week of the study.
Wow.
And this was led by nurses. They were trained up onto how to use the gene drive device and interpret the results, and then obviously determine which antibiotic the baby should be given.
Yeah, that is absolutely phenomenal. As somebody who is hard of hearing themselves, it's incredible to think that you can prevent a baby from experiencing that for the rest of their life. So what an amazing study. So thinking now about your current role, and as you've explained, you've got these split roles between the Northwest and the Northeast, but which bit of your current roles do you most enjoy or find most rewarding?
I suppose it's those moments which do happen when emails land on your computer, which you're not expecting. When somebody's found out about you, they know they have to look at genomics and deal with genomics because it's in Ruth May's strategy, long-term strategy, as the chief nurse for England. And you are then asked to be part of the group to raise awareness over the North East and Yorkshire. Yeah. So it's those moments which you know you can potentially make a difference, albeit a small difference, but you know you can reach the part that you know you have to get to.
Yeah, and I think that echoes Kay Cawthron's answer to that question, was that it was very much that kind of small but significant successes in that networking of actually seeing the picture come together in an instant when they can be very, difficult to achieve those contacts. So I think that echoes quite significantly what Kay answered to that. So on the flip side, which bits are the most challenging?
I suppose it's the complexities of what we're trying to achieve. And I suppose there's expectations of us to try to do this quickly. And it's managing those expectations within still in the post-COVID. We want to be able to pull nurses away for a period of time to raise their awareness and start the education. But we're fully aware that their time is taken up on the clinical area.
Absolutely.
And it's getting the balance right. And it doesn't matter which side of the Pennines I'm on. The struggles are the same wherever. And so, it's the complexities of managing our own expectations and expectations of our commissioners.
So what's a typical day like for you then?
I would say I turn the computer on because I work from home. So it's not travelling to my office. And I check when my first meetings are. Because we do a lot of Teams meetings within our role, because that's our way of communicating and raising awareness. And then I have 2 email addresses. One is my MFT account, for which over the past probably 6 months has become mainly my Northwest GMSA account and my NHS Net account, which is my Northeast and Yorkshire. So I have a pretty good divide as to what I do, and I have both those open at the same time. And it's a case of checking as to whether or not there's something I need to deal with immediately, or if there's anything that, if I need to go straight into a Teams meeting.
So looking to the future then, what is the most exciting bit that you see happening or coming in the near future for genomics?
Well, I would say it's the precision medicine and the advancement of genomics and personalised care. It opens up so many new possibilities for nurses. Of course, they'll be involved in genetic counselling to some degree, not obviously taking away the genetic counsellor role, but I certainly think they will be involved to some degree in doing a small amount of genetic counselling along the patient pathway, helping patients to understand their genetic risks and make informed decisions. Nurses can obviously play a crucial role in integrating genetic information into the patient care plans, and obviously providing education about the targeted therapies and the personalised care, which is, it's in current day, it's not the future to some degree, it's already here. And it's certainly evident in the cancer pathways of doing genomic tests prior to prescribing certain chemotherapies.
And what do you see as the kind of the barriers of getting, current day nurses into that space where they're using those bits of science?
Currently, time. They don't have the time to step away from the clinical area in order to undertake this kind of training that's required. So there is an element of try to do it by osmosis, lunch and learns, which I would say the best way is quick, short, targeted learning episodes that nurses can hook up to. Podcasts. Lunch and learns, as we've seen in the northeastern Yorkshire region, have been really successful, but yet they're only 40-45 minutes. So they are doable within the nursing day. But I would say certainly it's the time management. We struggle getting our mandatory training completed. And then getting extra training on top can cause a problem. But the best we can do is get out there, shout about what we do, tell them about genomics, and provide them with those hooks for them to see the benefit and to realise, actually, some of the nurses out there are already doing genomics. They just don't realise it.
Absolutely, it's that hidden iceberg, isn't it? And I think as well, part of the difficulty is that this is, this science has kind of exploded so quickly onto the scene that kind of the university and undergrad courses haven't had chance to introduce this heavily enough. So, those that are currently still in clinical practice that trained 10, 20 years ago will have done very, very little genetics or genomics. And whatever they did is probably not that relevant now anyway, because so much has changed. So I think it's the speed at which this has, the science has increased so rapidly. It's kind of trying to bring that into, as you say, a profession that's very, very busy on a day-to-day basis with the pressures of the NHS. So you mentioned in your job title as well about the Generation Study, and I wondered if you could tell me a little bit more about what that study is and maybe a little bit about what your role is with it.
So the Generation Study is looking at using whole genome sequencing on cord blood, so it's a sample taken at birth, on families who are recruited to the study, of which they have to fulfil certain eligibility criteria, as with any research trial. And I must impress that this is research. It's not current practice, so it's still in the research phase. And you have to be eligible, you have to be a resident in England. So it's not the devolved nations, so it's not Wales, Scotland and Ireland. Your GP has to be based in England. So you can live in Wales, but your GP has to be in England.
Okay.
Also have to be over 16. You have to be, it's carrying a singleton baby, so not one of twins or triplets. And the baby can't be given up for adoption or surrogacy. And once recruited, which the recruitment takes place from 20 weeks onwards, during that time. And at any point, as with any research trial, if you want to opt out of the study once recruited in, you can do. However, if you obviously opt to stay in the study, then it's a case of having the cord blood taken. That will then be sent to a laboratory outside of the NHS for analysis and interpretation. And whereas the current newborn screening, which is carried out at 5 days, on what's called a heel prick. They're looking for 9 or 10 different disorders. The massive difference for this is the fact that we're looking for over 220 disorders.
Wow.
The important factor to mention is that the disorders that they look for are treatable. There are treatments available for all in England, and they are funded treatments. So what I'm saying is that disorders will not be given to families for which there are no treatments. And that's in its simplistic form. We're looking for a turnaround time of testing for the cord blood to take in the first instance between 8 and 12 weeks, but they're hoping that the sample analysis will potentially speed up. And as regards my role for the Northwest, because I'm the Generation Study champion for the nursing and midwifery side, then my role currently is to engage the nurses who work along the 15 clinical pathways at both the Royal Manchester Children's Hospital and Alder Hey Children's Hospital, and speak to the clinicians along with the principal investigators, to raise their awareness and make them aware that this study will be starting later this year for the Northwest.
Yeah, and how perfectly placed you seem to be for that role. It's like it's made for you, Gill. So all that time of working in paediatric nursing, and as you say, the thought of possibly going to London at one point, but very much still being rooted in the Northwest, your connections within that must be incredibly helpful to the role that you're doing now.
Well, it sits very well because part of my role within the metabolic team was dealing with the raised results on the newborn screen.
Okay.
So I'm fully aware from PKU to isovaleric acidemia.
Yeah.
There's quite a few disorders already on the 5-day heel prick.
Yeah.
But of course, the numbers are far greater.
Yeah.
On the cord blood sampling.
Yeah. And I'm certainly really interested in, kind of the outcomes of the study in terms of even not so much the diagnoses that are made, because obviously at the positive end of that spectrum where you do identify children that are affected, the advantages of that are incredible. But I'm really looking forward to what comes out of the study in terms of the acceptance of doing this on a social level for people, and how Genomics sits in these pathways for essentially well families. So it should be a fantastic study
But the benefits are huge as regards ironing out the diagnostic odyssey.
Yes.
And the journey that some patients can go on for potentially months, if not years.
Yep.
And on, some occasions we're in situations where children will turn up to a consultant, a diagnosis is made, but unfortunately they've missed the chance to have effective treatment.
Yeah, absolutely.
And this is the benefit.
Yeah.
I absolutely appreciate, as with any research study, you have pros and cons. Mm-hmm. The benefit is that these babies are picked up and the difference can be made.
Yeah.
With some can be, absolutely life-changing.
Yeah.
And so it will be very interesting to see, but the key element is that it's research.
Yeah, and also kind of reflecting back on the cases that you described that were the ones that kind of you carry with you, is those cases where, as you mentioned about the second child being in pregnancy or very young, when the diagnosis is made in that older child, then essentially it would avoid that situation.
Absolutely,
so it's
yes,
interesting that that's the bit you see so positive of this, which of course is obviously one of the major strengths, but it's also what kind of has pulled at you from the cases that you carry with you from your clinical days.
Yes.
Well, Gill, it's been an absolute pleasure. So thank you so much for coming in to talk to us. And thanks to you for listening. If you'd like to learn more about some of the topics that we've discussed in this episode, then you can find the relevant links on our website, www.ney-genomics.org.uk/podcasts. Our website also has all of our other episodes in the podcast series, which are also available on Spotify, Apple Podcasts, and all other podcast platforms.